Hello professionals, this is Dr. Saad and as you know we are recording series of lecture for pharmacists who are going to appear for international equivalency exam and let's resume our topic that is the epilepsy. Point number one is about the epilepsy management in case of pregnancy. We use lamotrigine and levetiracetam for the management of epilepsy in case of pregnancy. These drugs are considered safer for in pregnancy. But remember, I don't have any bookish evidence for these point number one, so must consider authentic literature while using this point. Point number two is about the brief summary of all drugs which are part of prescription for management and for the treatment of epilepsy. We will give you a brief summary of all drugs. And out of them, number one is the sodium channel blocker. Its example is the carbamazepine, as we discussed. And second example is the lamotrigine. Lamotrigine is its maintenance dose is 225 mg to 375 mg per day, 2 times per day, and initial dose is 25 mg per day, and it can increase from to 50 mg every 1 to 2 week, and it is used for the management of focal seizure. Third drug is in sodium channel blocker is the glucosamide, and its dose is 50 mg 2 times per day and increased by 100 mg weekly interval, and it is also used for the management of focal seizure. Second class of drug that is the broad spectrum, it include valproic acid or sodium valproate as we discussed earlier. Second is the levetiracetam. Its dose is 500 to 1000 mg per day, and its dose can be increased from 2 to 4 weekly interval by 1000 mg. So its maximum dose which is recommended for this drug is the 3000 mg per day. It is also used for the focal seizure. Third drug is the topiramate. Topiramate, its beginning dose is 25 mg to 50 mg for newly diagnosed patients, and it can increase to 100 mg per day, and its maintenance dose is 200 to 400 mg per day. It is also used for focal seizure as well as tonic-clonic seizures. And other example of this broad spectrum class is the zonisamide and rufinamide. These are the example of other which come under this class. Third is the gepantenoids. Its example is the gabapentin, and its starting dose is almost, if you need a very rapid response, then its highest dose is required, that is the 3600 mg per day, but its usual dose is 900 mg per day, 3 times per day. It's also used for focal seizure. It's and fourth is the barbiturates, as we know about it, phenobarbital and primadone is the one of these examples. And fifth class is about absence seizure is the etosuxamide. It is, as we discussed in previous video, that it is the first line of management of epilepsy, for especially for absence seizure. Point number six is about the benzodiazepine. Its example is the diazepam and clonazepam. Just for reviewing, clonazepam dose is 0.5 mg to 1 mg per kg per day. Similarly, point number seven is the about GABA mechanism drug like tigabine and vigabatrin. These are the two drugs which increase GABA transmissions, and its dose is 50 to 150 mg per kg per day, and for adults 500 to 2 to 3 gram per day, 2 times per day. Vigabatrin is used. It is about the potassium channel opener. So its example is the rati retigabine and perma retigabine and primaprenil. Primapenil. Primapenil are the example of the potassium channel opener. So we use sodium channel blocker and broad spectrum and GABA and gabapentinoids and barbiturates and absence seizure related drugs and benzodiazepine, GABA and potassium channel openers for the management of epilepsy. These classes are more or less are used for the management of epilepsy. And so this was all about epilepsy. We just discussed some key points which can be part of an exam. So let's close this topic here, and we will start our new topic, that is the Parkinsonism and other movement disorder. Our major focus would be on Parkinsonism management, and other movement disorder will be discussed as less as we can, but mostly we'll talk about the Parkinsonism and its management. So just for introduction, Parkinsonism, as you know, Parkinsonism is a combination of few features. Number one, you will a person who is suffering from Parkinson's, you will feel in his body's muscle is rigidity, bradykinesia, tremor, and postural instability. A person wouldn't be in position to take a proper, well, like you can say, a person wouldn't be in position difficult to stay in upright position, or there will be a bradykinesia. It's like slowness of movement, or diminished spontaneous movement, or loss of normal activity, and slowness of voluntary movement, or impairing memory and judgment. These are all common features which is visible in person who is suffering from the Parkinson disease, and it is also known as Parkinsonism. So simply just for to keep few points in mind, patient will which will be very prominent in patients. Symptom is the rigidity, bradykinesia, tremor, and postural instability, and it can be due to variety of reasons, but mostly cause is idiopathic. Secondly, the second point which I want to tell you in this that Parkinsonism is especially movement disorder. It doesn't cause mental deviation, so it's a movement disorder. This was a brief introduction of Parkinson disease. So let's talk about its management strategies and drugs which are involved in its management. We will use, first of all, we have to know why Parkinson happens. It actually happens due to drop of dopamine level in substantia nigra. So we have to increase first of all the dopaminergic level. Secondly, there can side by side cholinergic transmission increases. It also causes its symptom like muscle rigidity, specifically due to the drop of dopamine level and increase in the Parkinson, increase in the cholinergic transmission. So we will use two-step approach. Number one, mostly we will manage this disease by increasing the dopamine level, and at a second stage we will use anti-muscarinic drugs to avoid other effects like muscle rigidity and tremors like this one. So to manage the dopamine, we will increase dopamine level, but dopamine itself doesn't cross blood-brain barrier. So we use its precursor, that is the levodopa. But with the levodopa, there is another problem, that is it metabolize and generates dopamine in peripheral area, which is not our area of target. So we will try to increase our dopamine approach maximum in central nervous system. So we use side by side levodopa carbidopa, which will inhibits its peripheral metabolism and generation of dopamine. So in this way, we will always use carbidopa in 25 mg and levodopa 100 mg 3 times per day in initial starting way. And normally, pharmaceutical preparation which is available for this combination is comes under the 1:10. Like dopaminergic carbidopa will be in 25 mg, and levodopa share would be in the same tablet would be up to 50 mg. In this way, these play a key role in the management of Parkinson disease by increasing the dopamine level, and carbidopa protect its metabolism in peripheral area. Another problem which is associated with the levodopa is you can say, it causes anorexia, nausea, and vomiting almost in 80% patient. That's why it's due to its this GIT's adverse, or you can say, side effect. We use domperidone in combination of these drugs to avoid this nausea, vomiting, and anorexia like symptoms. Secondly, we also try our best to avoid vitamin B in combination with you can say levodopa, because vitamin B increase the metabolism of levodopa and generates dopamine in peripheral area. So our, you can say, therapeutic concentration wouldn't be achieved if you use vitamin B6 in combination with the levodopa. So this OTC prescription should be avoided. OTC product should be avoided while person has the history of Parkinsonism and is using levodopa drug. So point number third is about the other drug, that is the monoamine oxidase inhibitor. Its example is this Lagiline. It is also part of prescription for management of Parkinsonism. It is used in 5 mg in breakfast and 5 mg in lunch. And the second example of monoamine oxidase inhibitor is Resiglin. Its dose is 1 mg per day, and it is used as an adjunctive therapy with for the management of Parkinson. But be careful from the hypertensive crisis, because as we discussed in previous video that tyramine containing food side by side use of monoamine oxidase inhibitor causes the chances of hypertensive crisis because of overproduction and unchecked control or unchecked unblocked level of norepinephrine. Point number four is about some side effect of levodopa. It causes specifically diplopia. It's a double vision and dark urine and postural hypotension. Mostly it causes postural hypertension, or you can say mostly it causes hypotension. But in some cases, levodopa can also cause hypertension. That cases are if you use massive dose of levodopa, or if you use with a non-selective monoamine oxidase inhibitor, or if you use with the sympathomimetic agents. So in this situation, it can cause hypertension, but mostly it causes hypotension. Point number five is about the anti-muscarinic action. As I told you that muscle rigidity is basically muscle rigidity is basically due to the decrease in dopaminergic level and increase in acetylcholine level. So we'll use anti-muscarinic agents, and we'll use dopaminergic agents to manage this situation. So as far as the anti-muscarinic agents are considered, procyclidine is an example of anti-muscarinic agent which is used in the management of Parkinson disease, and its dose is 7.5 mg to 30 mg daily. Point number seven is about the Parkinson inducers. There are some drugs which induces the Parkinson disease. Its example are anything which blocks the dopamine level, which actually induce the Parkinson disease. Its example is haloperidol and chlorpromazine and phenothiazine, and you can say heavy metals are also responsible for Parkinson acts as a Parkinson inducer. Side by side, resorpine is a drug of alpha blocker class. It's a drug. It also acts as an Parkinson inducer. But as long as haloperidol and clopyramide is chlorpromazine, chlorpromazine is considered. These both drugs are dopaminergic antagonists, and it is understandable that it drops the level of dopamine. That's why it induces the Parkinson disease. Haloperidol is also used for other movement and sound that appear repeatedly, like this syndrome known as mm, Tourette, like Tourette syndrome, and it is used specifically for this for the management of sound. And in this syndrome, people will repeat the sound and repeat the movement. This situation is also managed by the use of haloperidol, but it is a side thing. Our main topic of concern is the Parkinson inducer drug. An example is the haloperidol, as well as chlorpromazine and heavy metal, as well as resorpine. These are the example of drug which induces the Parkinson disease. Point number eight has already been discussed about the levodopa. How do it cause hypertension? Point number nine is about again the example of anti-muscarinic drug. It's an atropine-like drug. Its example is the ethopромazine. Ethopромazine is example of anti-muscarinic drug. It's like an atropine, and it is used in Parkinson disease management. Point number 10 is about the bromocriptine. Bromocriptine is a dopamine agonist. It is specifically used for hyperprolactemia. It actually bromocriptine play a key role in the suppression of anterior pituitary and to avoid the production of prolactin. That's why in this way it manages the hyperprolactemia. And it is also, you can say as it's the dopaminergic agonist, it is also used for the management of amenorrhea and galactorrhea. And its bromocriptine dose is 2.5 mg once per day, 2 times per day, or 3 times per day. So this was also relevant point. That's why I discussed here as bromocriptine is a dopaminergic agonist drug. Point number 11 is about the benzotropine. Benzotropine is an anticholinergic drug, or you can say anti-muscarinic drug. Its dose is 1 to 6 mg per day, and it is used specifically for the management of morning stiffness, rigidity associated with Parkinson disease. And it is recommended at bedtime. As you know, muscle rigidity and stiffness happens, so benztropine is one of the options to manage this. and it is recommended at bedtime at dose is 1 to 6 mg per day. 1 to 6 mg per day. Baclofen is an antispastic drug, and this was all about our topic. We will discuss the remaining part in next video, and it's not a too lengthy topic. The main thing was that we have to increase the dopamine level, and we have to decrease the muscarinic level to avoid the movement disorder, you can say Parkinsonism, that is the muscle rigidity and postural instability, and you can say tremor, and like this one, and bradykinesia, to manage the situation. So thank you so much for listening, and if you feel that our this effort is supportive for you, then please appreciate me by subscribing my channel. Stay tuned.